Right, so thank you very much, Dr. Musa, Dr. Abdullah, for the kind invitation to come and present here. So, esteemed panel, I think Mohaned's done a lot of the hard work trying to explain perforations, and this case will just sort of take you through some of the complications that can arise and how you sort of deal with them acutely. So this is a 77-year-old gentleman who presented to us. He's had a previous bypass with a lemur to the LAD and a vein graft to the PDA. And as you can see, he's got an infra-posterior ST elevation myocardial infarction. So he's brought in on the primary PCI pathway. And we elect to do his angiogram from the left radial artery approach, particularly cognizant of the fact that he's had a previous surgery. So lemur to the LAD is widely patent. His grafts were put on about 15 years ago. Not surprisingly, the vein graft to the PDA is occluded. He's got diffuse disease in his native RCA. We felt that the culprit here was this thrombotic-looking lesion in this big OM branch. And you can see the AV circumflex is also important because it's providing collaterals to the PLV and PDA system. So the strategy was to think about intervening on this. This is a 6-French catheter setup. The vessel was wired with some difficulty, I have to say. It was quite gritty. You could tell that actually, rather than thrombotic lesion, we were dealing with a calcific lesion here. That's why I went with a 2.0 balloon, and unfortunately that balloon is not able to pass. So, you know, you're stuck in a difficult situation here, and the question is, you know, what do you do in terms of escalation of your strategies here? So initially I tried a Caravel microcatheter, but that would not pass, so it was quite clear that we were dealing with calcium, probably a calcific nodule here. Eventually I decided then to take the turnpike spiral, which is then spun down into the vessel. It's the microcatheter with nylon threads on it. I switched out to a rotor floppy wire, and we did rotablation with a 1.5 burr here, 3 passes at 175,000 RPM. Now, the picture here is very telling. So we were then able to get our 3.0 non-compliant balloon down. And as you can see there, as the balloon is inflated, it suddenly just ruptures. Fortunately, it was well prepared by my fellow, but this is probably due to a calcific spicule that is still present despite the rotational atherectomy that we had done. So at this stage, as Mohaned mentioned, you should always take a picture. That balloon was not going to be of any use to us because, of course, it's ruptured, so I had no option but to remove that balloon. This is the type 3 perforation that we're experiencing now on the right-hand side of the panel. So another balloon is taken up pretty promptly, and as was mentioned, I sort of use the acronym block and deliver. This is something that is very bad that has happened, so having acronyms in these situations where you have an acute complication are particularly helpful. So a 3.0 non-compliant balloon was then put up, and this gives you time to sort of think, gather your thoughts and decide on what you're going to do next. You know, of course, the patient will have ST segment elevation. They will get worse, so you have to give them some upfront pain relief for this. So as was mentioned, you know, we thought about putting in a second guiding catheter, thinking about the ping-pong technique. In that meantime, whilst we're sort of deliberating about what to do, we decided to do an echocardiogram. Remember, this is a patient who's had a bypass, so there was no collection that we could appreciate, and he was reasonably stable from a hemodynamic perspective. So actually what we did was put a parallel wire down, so the balloon is deflated very quickly, and the wire, which is a standard workhorse wire, is then put down into a small sub-branch of the OM here, and the balloon is inflated once again. Now, with type 3 perforations, of course, you know, almost invariably need to get those covered. We have the papyrus stent available on our shelf. This is a polyurethane stent. And the nice thing about it is, of course, that it's 5 French deliverable. So, we are in a 6 French system here. So the trick that we used here was really to get the papyrus loaded up onto that second wire. And again, whilst we deflated that first balloon on the first wire, the papyrus was then popped across into this perforated segment. The first wire and balloon are then removed. You can see that in the middle panel, and the papyrus is deployed. Now, sometimes it's quite difficult to work out exactly where that perforation is coming from, but we wanted to stay distal to that AV circumflex because, of course, it's providing collaterals, important collaterals to that right coronary artery. So that's the papyrus that goes up. Now, despite that deployment, and this is after post-dilatation, by the way, you have to do aggressive post-dilatation in these covered stents, we had a persistent leak. And in fact, after post-dilatation, the leak actually got worse rather than better. So we kept our balloon up there. Sometimes keeping your balloon up, maintaining an ACT of around 250 rather than 300 can help seal that. But about 15, 20 minutes into the case, we hadn't really made any progress. So the decision was made, therefore, then to think about whether this could be an endo leak, a little bit akin to what you see in peripheral vascular intervention, particularly when you're dealing with large aneurysms. We felt this probably was a leak that was coming more proximally to where we deployed our covered stent. And of course, very proximal to that is that important AV circumflex branch. Now, it was a little bit challenging, I have to say, and I can't really explain why this is, but getting the second covered stent in, even though the first one had gone in so easily, was particularly challenging. We had to use a guide extension catheter then to help deploy that second covered stent. And as a result of that, we were kind of focusing in on that segment of vessel. So the second covered stent is then put in. And we thought we'd finished. Obviously, the AV circumflex has had to be sacrificed in this case to deal with this perforation. And my wire has come back, and I thought we'd sort of done the job. This is about an hour and a half into the case. And then we realized, actually, what's happened here is that we've ended up with a type 5 distal wire perforation. I think this has probably happened because we weren't really focusing on where the distal wire was, and probably because I was struggling to get this covered stent in. So as Mahan had mentioned, you have to know about your equipment, and we have these Cook microcoils available in our cath lab. They have to be delivered through a dedicated cantata microcatheter, unlike other coils which you can deliver down fine cross microcatheters. So the cantata microcatheter was popped in here. They come in a variety of shapes and sizes. I elected to put two 2x2 millimeter microcoils in here, and of course they've got these microfilaments on which are thrombogenic, which then basically seal off that distal perforation, which we were able to do quite successfully. And it was only then at that stage that we decided to end the case, and after successfully sealing the perforation, and reverse the heparin with protamine. So these are my sort of take-home messages on this case. I think, dealing with calcific lesions can be particularly challenging. We are seeing more of this. We don't have a huge experience of doing atherectomy in the setting of a primary PCI, but I think it's something that we're going to have to deal with more and more, particularly as our patients are getting older, presenting with more calcific disease. You always have to be aware of complications that can occur after rotablation. Obviously, we were dealing with a type 3 perforation, which was probably an endoleak type, so you can't always be certain where to put your covered stent. Sometimes you have to use a second covered stent, even if perforation continues. And always stay focused and avoid sort of tunnel vision. I think that was one of the problems that happened with me in this case, that I was so focused on dealing with this perforation that I sort of lost view of the larger picture and ended up with a type 5 perforation. That was not a hydrophilic wire, but a regular wire. So perforations can happen with regular wires. He ended up staying probably a couple more days than he would have done otherwise, but he was successfully discharged home on day 4. Thanks very much.
Thank you very much.